Okay, welcome everybody. Thank you for taking time out of your busy week to join us again. I know there's a few people straggling in here, but we're going to go ahead and get started. It looks like, we've had about 50 dentists, Guy, log into every single one of these webinars so far, and then we get about another 50 new people. So we have said we're saving the best for last. In that sense, we know that a lot of you want to learn about how to market this in your own practice and how to get paid. So look forward to talking to you guys tonight about this. We're putting this on in conjunction with Keller Laboratories. As you all know, if you've used Keller, about their great customer service, and they do a lot of things besides sleep medicine appliances, but we encourage you to use them for their services, and we appreciate their help in doing this. Guy, tell them a little bit about us.
Well, we're Dental Sleep Solutions, and Rich and I have worked feverishly over the last going on 4 years to put all the pieces of the puzzle together for dentists who want to rapidly get involved in this and be the go-to dentist, from software to training. We really feel like we've got it covered. And if you're interested in hearing more about that, please contact us at dentalsleepsolutions.com. Okay, and who we are? Well,
you've seen these mugshots before, so Guy and I have both been doing this for quite some time now, and if you've listened to any of the other webinars, we hope that you've gotten something out of those, and we hope you get something out of this one tonight. Let's talk about the CE real quick.
Yeah, if you want to get your CE credit, a little house cleaning here, make sure once you receive the email from Dental Sleep Solutions, which we will send you an email to the email address that you registered with. There's going to be a 10-question quiz. You've got to answer that within 7 days of receiving the email, and then click on the email and enter the required information, complete the quiz, give us your AGD number. If you don't have one, then put NA, and you'll get your 1 hour of CE for spending the evening with us.
Great. Well, okay. Well, let's go ahead and get started. Learning objectives tonight. We really want you guys to try to get your arms around this tonight. When we talk about marketing this, we're going to talk about, who we're marketing it to and what we're doing, and talk a little bit about the skills that you can use during consultations to help get patients to accept this treatment option. The caveats of filing insurance. We could easily speak for 8 hours about insurance alone. So we've got a lot to go over, and we want to give you the nuts and bolts. You can do a search of webinars out there, and you can find some other ones, even that Keller's done. And the one that they did before was good, and it was kind of a broad sense of what happens in insurance. We want to give you some specifics. We want to give you some things that tonight you can take away and actually implement in your practice tomorrow. What codes to use and what forms to use and what supporting documentation you need, all of those types of things, so that you all can get going with this. First, we're going to talk about practice building. I want to preface this a little bit with, what are you selling and who are you selling it to? We are healthcare providers. We've crossed a line from dentistry into medicine when we're doing dental devices to treat sleep apnea. And one of the things that Guy and I have always said, the mantras we've stuck to with Dental Sleep Solutions, is that if you keep the patient's best interest at heart, it's hard to get too far offline. And we feel strongly about that. But at the same time, we are trying to get them to accept a treatment. And let's talk about some of the different things that includes.
Well, what you said, Rich, I want to just reiterate, or at least emphasize, is one of the things I love about dental sleep medicine is it's very easy to be passionate about it and believe in it. You don't get a second chance. If your tooth has a big amalgam in it and it breaks, we can usually do a crown or a root canal or even an implant. You die of a heart attack and that's it. You've lost your chance. So it's real easy to be passionate about this. And these are some of the words or things you want to talk about with your patients. The correct verbiage and communicating with them. Let your patients know that their risk of heart attacks and strokes goes up, that correct treatment will lower blood pressure. You'll feel rested at night. You're going to live healthier. People are going to live longer and healthier. You're going to sleep quieter for your spouse, and you're going to have more wits about yourself the next day. You're not getting the proper REM sleep will cause cognitive impairment, and getting the appropriate amounts of the right sleep stages will make a person be much sharper the next day. And driving, there's a big push in DOT, as we mentioned earlier in some of our other webinars. That's because driving while sleepy is very dangerous, and it's easier to lose weight. One of the treatments for sleep apnea is weight loss, and certainly it's very effective. It can certainly decrease apnea, but it's hard to go to the gym and work out when you don't feel rested. And there's even things on a hormonal level of not sleeping properly, which increases weight and decreases the body's metabolism, so to speak.
Yeah, there's lots and lots of things that we could add to this list. One of the things that I want to point out, and that's good, Guy, is that we tend as healthcare people to want to talk about the things we read about in peer-reviewed journals and in scientific magazines. We want to tell them your risk of heart attack is going to go down. Well, if a patient hasn't had a heart attack, that doesn't mean a lot to them. If they have had a heart attack and you tell them that if you do this, your chances of having another heart attack go down, now that means something. But the other types of things that are more towards the bottom of this list, those are the things that patients hear. We can talk for a long time, but patients don't always hear what we say, right? I know one of the earlier webinars, Guy, you had that slide that you had made about the patient's awareness of the problem and their willingness to accept treatment. So we're trying to increase the patient's awareness of what this problem is and what those risks are so that we make them more likely to walk down this path towards some type of treatment. It's okay. Let's go to the next slide.
So there's plenty of opportunities out there to find the patient who have this problem, and most of them don't know they have this problem, as we've mentioned previously, in your own practice. And as we start training new dentists or getting them involved in this, most people have a gold mine right in their own practice if you just start doing the screenings that we've mentioned before. Dentists and physicians, a lot of dentists, as they become educated and maybe they don't feel comfortable treating this in their own practice, I get quite a few referrals from dentists in my community. And so educating them on this, don't feel like they're going to be competition to you. Any kind of physician. Rich, I think his biggest referrals from a gastroenterologist, is that correct?
It's actually a rheumatologist.
Rheumatologist, okay.
Yeah.
And like I have an ENT is one of my bigger ones, a sleep physician in one of the other offices. So all physicians, some primary carers are very good once they accept this. It's just that the physicians who get this and start understanding the correlation to the health problems as well as the fact that dentists can help this, just invaluable as far as the number of referrals you can get from people like that. Sleep docs, of course, and sleep labs, but DME companies, nowadays with the chips in all the CPAPs and they're having the compliance monitoring, these people are bringing their CPAPs back when they're not compliant. Medicare won't pay for them anymore. They have to turn them back into the DME company. And we can just talk to these people and say, look, these people who turn them back in, here's a solution for them. If we just even get those, there's a lot of those out there. The general public, I talk about sleep everywhere I go. People ask what I do, and, I tell them I'm a dentist, but this is what I do mostly. And, boy, people just love talking about it, more so than dentistry and public speaking and a lot of various ways to get the word out in the public.
Very good, Guy. And these are all just kind of general areas that we feel like you have an opportunity to make an impact in the people that are out there. So the next slide we've shown this before on our previous webinars, but I wanted to put this in here again to show that we dentists are the best healthcare providers to provide introduction into the patient's mind about what this problem is and to walk them down the road towards treatment. So we've talked before about how there's different areas where these patients can plug into the treatment protocol. We've gone over that, but we want to re-emphasize the fact that as dentists, we can be screening for this and we can get patients introduced into the treatment model that goes forward. So first, we're going to talk about opportunities in your own practice. These patients have been walking through our doors for years, and we just not recognize them. So now we want to start to find them. Case finding. I know that some of the practice softwares out there, you can filter patient searches. So one of the previous webinars, we talked about bruxing and how that relates to sleep apnea. You could maybe put a code into your practice software that says, I want to screen all my patients that I've made a night guard for. That may be one way to do this. You could screen for all of your patients who have hypertension, and you can get lists that way. So there's several red flags that come up when we want to start to look at which patients are the most likely to have this problem. we want to kind of screen everyone, but at the same time, we want to pick out the patients that we think might very well have this problem and to bring it to their attention and talk about it. So, within our own practice, we can make brochures and have posters and statement stuffers. I think if I could redo this slide, Guy, I would probably put educate staff all the way up to the top too, because, we think as dentists that the patients listen to us, and the reality is they listen more to our staff.
Absolutely. Staff educated, especially your hygienist, certainly at least one of your assistants, knowing about this. The hygienists spend more time with the patients than anybody else in the office. So having them educated on this is ideal for your practice. They can do a lot of talking, just like they do about other treatments that you have available in your office. These posters, we put these in those little acrylic stands. And we have little bay windows in each of the operatories. If you have a shelf or wherever to put them, we have one in the reception room. We have one as you check out. And then all the operatories, when the patient's sitting up in the chair, they're looking at this thing. And every day someone asks about it. It just makes sure that they know that you're involved in this, and having some sort of notice of that in your office will bring up conversations.
That's a good point. I think especially make sure that your patients know you provide this service.
Yeah, even sending out a letter, I think, once you first start doing this, maybe a letter to your patients with maybe a new brochure that you've done, and letting them know that you're getting involved in this, and this is a new part of dental medicine, and being on the forefront that your office is, that we're now screening and providing these services in our office.
Yeah, how do you use your brochures in your practice, Guy?
Well, we use them that way. When you first started getting involved, we send them to all of our patients. All new patients, even in the restorative practice, will get a brochure on sleep. And then we also use them to give to all the medical referral community. We have them in restaurants out here on the island, Anna Maria Island, where one of my offices are. They let me put them in a restaurant. So just anywhere that the public, you might want to educate the public. It's a brochure that's basically education for the public and about what sleep apnea is, and snoring, how it's related, and how dentists can help. So I use them. We go through a lot of brochures, but it's worth every penny because it gets your name in front of people.
Yeah, and the poster that you made, I know we have several of those at Dental Sleep Solutions that we've developed, and we've paid people to do that. But I want to let the dentists know out there that a lot of the appliance manufacturers have these as well. In other words, if you contact Keller Lab, they can point you to the EMA people, the TAP people, and they have posters that they will send you, that you can do the same type of thing. Put them in those acrylic things and put them in your operatories and stuff like that. So we're going to try to give you lots of good ideas that don't cost a lot of money. If you can just call and make some of these calls, you can get a lot of this stuff and you can use it. It won't be personalized with your name on it, but there are brochures and there are posters out there that the appliance manufacturers make, and you can get those.
Once you get educated, I suggest you start with some of your own staff and your own patients and relatives, and maybe even yourself with apnea. But once you start getting a little comfortable with this, I wouldn't do it the first appliance you make. But once you've done a few and you're feeling a little more comfortable, then the best investment of your time by far can be networking with the medical community, whether it's doing lunch and learns or just stopping by to take 15 minutes of their time and give them some brochures, or taking a doctor to lunch. Whatever way you can interact with them, it's going to pay off big time, and at least in our experience. Which with the medical community in general, sleep labs, all kinds of MDs, dentists, as we've mentioned, I think it's important to spend time in a sleep lab. If you show that kind of interest and ask them, say, can I come over one night and observe while you're doing some sleep testing? Most labs will welcome you. As a matter of fact, they need a dentist on their accreditation board. When they get accredited, they normally need a dentist to sign off and to meet with the, I don't know who does those, Rich, evaluator, whatever he is. I've done it a few times for labs, and so they appreciate you being involved. And I think you'll learn a lot from the registered polysomnograph technicians who are there overnight, and also to go to help towards your diplomate status as well, and go visit with DME even though they're somewhat competition for us, a lot of them are very open and are happy to talk to you and glad that they have someone.
What's a DME company?
Very good, yes. durable medical equipment companies, which dental appliances for sleep apnea are considered durable medical equipment, and so is CPAP. So these are the companies who dispense CPAP. If you have a sleep test and they determine you need a CPAP, they run a trial on CPAP with their titration study, and then they give you a prescription for a CPAP, and this is where you go get it, just like if you needed a crutch or something like that, wheelchair. That's a durable medical equipment. That's what both our appliances and CPAP fall under.
Now, when you say go visit these companies, are you talking about actually physically walking in the door and introducing yourself?
You can, or you can call them on the phone. But yes, sometimes these companies don't necessarily have a store. Some of them are home-based, so you might ask for them to come by to meet you because they don't all have a big office per se. A lot of them, they deliver the CPAP to the patient's house. But yes, either way, how do you handle that, Rich?
Yeah, when I first got started, I can't tell you how many of these I walked into. And I handed them some business cards, and I handed them some of my brochures, and I said, just throw me a bone. I mean, just a crumb. I kind of went in, with that type of attitude that when you have patients that just can't deal with CPAP, please let them know that I'm out there and I can help them. So that kind of gave them hey, this guy's just here to help us for patients that can't use CPAP. It wasn't like I was trying to compete with them. So like you said, the smart ones will understand that you're a competitor of theirs. And so you're just there to say, hey, if somebody fails CPAP, I would really appreciate you telling them about my device. If they can't use a dental device, I'm certainly going to tell them about you.
Absolutely. And we send tons of people for CPAP. Everybody's not a candidate for a dental device. And the more severe cases, maybe lack of adequate dentition, lots of reasons for that. But let them know that it'll be a two-way stream. And that always seems to help.
All right, ride the trend. You can't pick up a journal today or a magazine or a newspaper or hardly anything without reading about sleep apnea being the next disease of this century and what the problems that patients have and how it affects literally every single organ system in the body. And, I heard a physician say the other day, if it's not cancer, sleep apnea makes it worse. And I'm not so sure about the cancer part of it. So it just makes everything worse. And as dentists, we have less than 1% of the market share on the treatment side. I know Guy and I, one of the reasons we started Dental Sleep Solutions was to help dentists do this, and we really want to change how this is done in the United States. We want dentists to have 25 to 50% of the treatment side of this. And we do that one dentist, one patient, one physician at a time. So we go out there and introduce ourselves, and we talk about this every chance we get. And, we just put that hat on and we wear it and proud of it. Let's ride the trend while it's there. We fought some battles in dentistry where we were going upstream. Now we're going downstream. So let's take advantage of that.
Absolutely. Things have gotten, we've both been involved in this over 10 years. And even in the last 2 years, things have gotten a lot better for dentists. It's easier to get insurance. It's easier. The trend is definitely going in our direction. We just need to hop on. There's a lot of opportunities out there. And if I had to say the number one thing to building a referral-based sleep practice, it's consistent and quality communication with the medical community. So just letters. Every time you get a chance to send something to a member of the medical community, be it a dentist or a physician, copy all the patient's contacts and send them. Thank you for the referrals. We're beginning treatment. We're in the middle of treatment. We're finished with treatment. Even when they don't accept treatment, make sure that the letters get out there. And if you were to call here in the west coast of Florida and ask just a random physician or somebody in sleep in particular, where do I send a patient that needs an appliance? They're going to say my name or Dental Sleep Solutions because I've been in front of them constantly. That's the number one thing. We already talked about the brochures, but once you start getting some networking and take the brochures, we kind of go on about every 6 weeks, my staff will go around to all the referral sources and take donuts or brochures or what have you and drop them off at these offices. And that really, it just reminds them that you're there. If you have the practice parameters with you when you have these meetings, and again, we're referring back to the 2006 AASM practice parameters where they basically said that dental appliances are approved for mild to moderate apnea as a choice as compared to CPAP, and anybody who can't tolerate CPAP, if they're severe, can have an appliance. Take those with you, because sometimes the physicians, in particular primary cares who aren't involved in sleep, don't realize that dental appliances should be given as an option, and say, here, look, this is the way it's supposed to be done according to your associations. And they, it kind of opens up their eyes. Anytime you can have a conversation, if you get a patient and you're wanting to network with that new physician and you've not seen him yet, then call him up and say, look, I'm seeing Mr. Jones. I wanted to let you know what we're doing. He can't wear his CPAP even though he's severe, or maybe he's not severe, and we're doing this as a first line. Whatever it is, as an opportunity to call and talk to him on the phone is always a good idea. Becoming an expert. I mean, the more you know when you talk to these people and they realize that you've taken the effort to get educated and that you understand about sleep apnea, it really helps. Anytime you can give a lecture, I think I skipped over that one, but Kiwanis Club, Rotary, Yacht Club, they have a great mates at our yacht club, which is the mostly females, which are happy to hear how you can help their husbands snore. Anytime you can get in front of a group and talk, if you're comfortable doing that. And if you're not, maybe one of your staff members are. Some of my staff does these things. They do awake groups, which are basically CPAP support groups. This AWAKE, Awake. Look at that. Most of your hospitals will have those, and they love to have dentists come and talk. So anytime you get in front of somebody and you know what you're talking about, you're going to get some attention.
Now, this slide, under the heading under this slide we have is other dentists, and I'm kind of curious, Guy, what
I got off the subject there a little bit.
No, it's pretty much the same. I mean, we're getting out there and we're reaching out into the community, and we're going to talk about, some of the differences, and that's why I bring it up now. My practice, this is all I do for 10 years now. So I kind of have a little different maybe perception of the relationship with dentists and how I do this, but I know a lot of dentists out there, and we got a couple of questions coming in now about people are asking, well, look, I'm a dentist. This guy is my competition down the street. Yeah, but you've taken a course. He hasn't. If, you can certainly support their efforts in what they're doing, just like you can if a colleague calls you up and he says, hey, man, I got this tooth that's really bothering the patient. What do you think I should do? You can certainly help them in that sense, just like you would if somebody's going to do this. So what you want to do to separate yourself from the other dentists in the community is to do these other things that we're talking about, where you become the expert. So what has your relationship with other dentists? Because I know you do mostly sleep, Guy, but you also do some general dentistry still. What is that relationship? Because some of the questions coming in are dealing with that,
right.
With these other people in your community.
Very good point. And like I said, I kind of got off the subject there, and I apologize about that. But I get a lot of referrals from dentists, and I'm doing mostly sleep now. And you got to be just like another referral specialty, rather, like a periodontist or an orthodontist. They realize that it's something that they're not comfortable doing in their own office, and they send them to you, and you got to make sure that you send them back. One of the key things you can do is there's a filling that looks like it's about to break, and they need a crown. You can mention to the patient, look, I really think this tooth needs to be crowned, and they'll say, oh, yeah, he's been telling me that for years. Well, why don't you go get that crown so we don't have to jerry rig the appliance down the road when you have it done. Okay. Well, boy, they love that. Their patient comes to you, and next thing you know, they're finally doing that crown they've been bugging them to do for 2 years. And then I also have patients that ask me, well, I want to be your dentist. I want you to be my dentist now, rather. Can I come here for my dental work? And that's an ethical decision you're going to have to make. And my policy has always been no. If you have a dentist in the community, they come to me just to have this treatment for sleep apnea. If they're not happy with their current dentist, then I say, look, you're going to have to find someone other than our office, because, that'll cut off that referral source. And I think the dentists in my area at least realize that even though we do general dentistry here, my associate does most of it now, but we're not going to steal their patients. And I think that that's real important for the dentist to realize too. And it doesn't even hurt just to tell them that. Look, I'll make sure they come back to you. We'll do this, and then they'll come back to you. Let them know we're not trying to steal their restorative patients.
That's a good point. Okay, let's move on. Let's talk. And again, like I said, I don't think you were really off topic at all there, Guy. A lot of these things that we do for dentists to market our sleep practice, we're going to do the same thing for the physicians. And number one there is to create a relationship. Think about who you do business with as a dentist. they are your friends. They are people that you know, that you have a relationship with. So don't just send a letter. Is there anything wrong with sending a letter to the sleep docs in your community or the physicians in your community? Absolutely not. Is there anything wrong with sending them brochures? No. But we still want to reach out and try to meet these people and do this. So you can do that through lecturing to the public as well as to physician groups. They do grand rounds at hospitals. They do some of the medical societies will get dentists in to come in and talk about dental devices. So you can go to the dental society meetings. You can go to the medical society meetings. You can network that way. We mentioned going to the sleep labs already. That kind of gets you an in where the docs come and they talk to the techs, and the techs say, hey, man, Dr. Yatro showed up the other night. I can't believe that. He's a dentist in town. Oh, really? The next slide, we go in there and we include some of our marketing materials from business cards and brochures and that type of thing. And don't forget, you can take them an oral appliance. You can get EMA samples made very, very cheaply, if next to nothing. You can get tap samples. I know that Keller will help you out with that, give you a pretty good deal on that. So, a lot of my best referring physicians have all of these things sitting on their desk when they're consulting with patients.
Absolutely. If they're just sitting there and the patient asks what it is, it's just great to have them around their office. Again, you get the EMA ones very inexpensively and give those to all your referring docs. They want to have something in their hand. The patient wants to see something, so that's a great point.
Anything else on this? I know you mentioned becoming the expert, Guy. How do you do that? How do you become the expert?
Well, it's I think it's education, and that's what you're doing here tonight. Many courses and reading the books we've mentioned, to read those. I think that's key is having your knowledge. And then the way that you get recognized as the expert is going out and meeting people. When you go have lunch with a sleep physician and you can talk to them eye to eye and they realize that you know a whole lot about this and that you really have taken the time to become educated on it and that you're serious about treating sleep apnea with dental appliances, they're impressed. I mean, don't you get that, Rich? They're like, wow. And then the word gets out and, you start doing that with lots of the medical community. They realize that, as far as treating sleep apnea with oral appliances, Yatros or Drake or Dental Sleep Solutions or John Smith down the road, if he's the one doing it, is the person to go to.
Absolutely. Knowledge is power. We've said that every single webinar we've done and every course that we teach. And when you can sit down and speak with a physician at their level, when your knowledge gets to that point, you're going to get referrals.
And one thing I want to say is, people maybe think, oh, well, how, it takes years to get that way. As far as becoming an expert in something in dentistry, if you want to be the veneer expert or the implant expert, it's going to take you a lot longer to get recognized as that individual. I can think of no other aspect of dentistry that you can become the expert at as easily. It really is not as complicated because you don't have all the mechanical and the mental and when it comes to doing things with your hands. This is just basically knowledge. If you can read and retain what you read and take a few courses, your knowledge can be there. And then to become the expert, you've got to let people know that you know these things. It's not as difficult as it is becoming experts in other areas of dentistry, I don't believe.
That's a good point.
I like to say it's really difficult and make us sound wonderful, but it really isn't that. Compared to everything else, it's not nearly as complicated as becoming an implant expert or something, we'll say.
Right. And that the positive that you all have is you're listening to a webinar, you're trying to educate yourselves, you're already starting to separate yourself from the crowd. We wonder all the time why most dentists simply don't get this. And I don't understand why most dentists don't get it, but use that to your advantage at this point. You be ahead of the curve. You do get it. You become the expert. You become the go-to guy in your community, and then you have an in, and you're one step ahead. So what are some of the other things that you do out to the consumer at large, Guy?
Yeah, well, we've talked about opportunities with your dentist, talked about opportunities with the dentist in your community, rather, opportunities with the medical community. And now we want to talk about the public, getting them to understand that you are involved in this. Public speaking, we've mentioned, advertising, print and radio. I think radio is probably a better bang for your buck, at least in my experience. Direct mail can be effective. Anytime there's an opportunity to speak, and again, everybody's not comfortable with this, but maybe when your staff members are. I have staff members who do these awake meetings, and you see on the right side of the screen, awake is, again, it's like CPAP Anonymous or something. It's a CPAP
yeah, it's kind of like an awareness
group.
Yeah.
It's for people having trouble with their CPAP, and a lot of times the hospitals will have these, and they'll want people to speak. Just any time that someone asks what you do. I'm a dentist, but I do a lot of this as well. And you mentioned snoring and sleep apnea. They love talking about it. I have the back of my car with one of those kind of screen things that you can see through from the inside, but the outside looks like a billboard. And I have an advertisement on it. Stops snoring and sleep apnea, and it's got some information about our website. And I get people to stop me all the time. What is the CPAP alternative? Tell me about this. I literally carry brochures in my car because people will stop me. I've handed them across the lanes of traffic at a stoplight before.
Yeah, I want to tell a quick funny story about that guy. I've got a magnet on the back of my truck. It says, "Stop snoring, treat sleep apnea." 210-541-9001. It's my phone number, right? So one day, a potential patient calls the office, and Molly answers and says, good morning, whatever. And the guy says, "Wait, is this the guy that does the sleep apnea stuff?" And she said, yeah, it is. And he says, "Oh, thank goodness, man. This white truck just went by doing about 90, and we were trying to write the number down, before he got out of sight." So
got to slow down, buddy.
Yeah, I got busted that morning. But you're right. I mean, that magnet cost me $45, and I make about 4 or 5 devices a year because of that magnet.
I think I paid $250 for the whole screen, and I got that back the first month. So it's nice. People know you do this. Signs in your office. If you have a sign that's on your street for your dental office, and you've got room to put something on it about treating sleep apnea, just get the word out to the public. And again, if you're going to pay for advertising, I would say radio, print. I've done billboards. I find them to be a little less effective. Anything else on that subject?
No, and I really think that we want you, dentists, to get out of your comfort zone. You don't want to hear us say that, but in order for you to do this, you have to get outside of your comfort zone a little bit. And part of that is public speaking. I mean, I did a course the other day at the Health Science Center here in San Antonio, and I said, think back to when you were in dental school and that oral surgeon sitting there, and he tells you, "Okay, get in there and get that tooth out." And you've never taken a tooth out before. Well, I'm not sure I want you that far out of your comfort zone, but we do want you out of your comfort zone because you're going to have to learn how to do this. You've got to take impressions. You've got to make devices. You've got a great lab here that we're working with through Keller Lab. They're very supportive. They can answer questions for you, so they can get you started with the TAP or the EMA, and those are 2 great devices to learn how to do this on. So again, get out there and do this. Get out there and talk about it. When we talk about public speaking, Guy, what do you have? Do you have a little PowerPoint that you do when you go to do these talks at Rotaries, or how do you do that?
Yeah, in general, I'll do a PowerPoint, but you don't have to. Sometimes if you just take some of your models, some EMA or TAP models with you, some brochures, and just talk. Depends on how, if it's a small group and they're just having lunch and you can sit at the table with them and just pass out the brochures and say, "Here's some of the appliances, here's how they work." Sometimes I'll take this anatomical photo that you've seen in some of the other webinars and show, well, this is where the obstructions occur and this is how it is. You don't have to have a PowerPoint to do it. If you need a PowerPoint and you want to do it that way, you can get a pretty good one off if you remember the American Academy of Dental Sleep Medicine. I don't know how much it is, but I think it's around $100 and something. They'll send you. There's one for the public and there's one for the medical community. I'm pretty sure. Isn't that correct, Rich?
Yeah, some guy I know put those together.
I think it was you, wasn't it?
Yeah. Anyway.
Yeah. So.
But you can get that, and we encourage everybody to become a member of the American Academy of Dental Sleep Medicine. That's just a couple $100 a year. So Those are all good points. So anything else about the marketing, that type of stuff, Guy, you want to add before we get into insurance?
No, I mean, that's the marketing's how we're going to get people through the door. And then the first question out of their mouth is going to be, how much is it and what does my insurance pay? Or probably the other way around. Is it covered by my insurance? And
right.
So that's what we're going to spend the rest of the webinar with. I think we've given you plenty of good ideas on how to get the patients through the door. So when they come through, you're going to have to be prepared to answer the question, how much is my insurance covering on this? And how much is this going to cost me? So that's what we're going to talk about now. Is it medical or dental we're talking about when we're doing that, Rich? It's medical only.
Right. And most patients don't even understand this. They're assuming that it's going to be, well, what is my dental cover? Well, it's not dental, it's medical. So we want to make sure that they understand that up front, and certainly that you do, so that you can convey that to them. E0486, we're going to kind of hammer that into your brain over the next several slides. That's the code for a custom fabricated device. Some of the things we're going to talk about as we get into insurance are, pre-authorization, in-network, out-network, out-of-network. What type of supporting documentation do we need? So these are all questions that you can ask the medical insurance representative when you call to verify the patient's benefits and those types of things. So we could get into all of this, but instead we're just going to say good luck.
Good luck.
No, we're kidding. We're not going to do that.
Okay.
No one out there has done this successfully. And again, this is, an 8-hour lecture to go into all of this, but we want to give you some nuts and bolts. There are some other, I know Keller has on their website another webinar that really is very, very broad information about healthcare and insurance coverage. We want to start to get into some of the nitty gritty now. So when we talk about coding and how we do this, there's level 1 and level 2 codes. Level 1 is the CPT, current procedural terminology, and level 2 is what Medicare uses through what's called the HCPCS. You'll hear that, and that's what you'll know. That's what they're talking about, and those are the E codes that are used for durable medical equipment in Medicare. And also most of the medical insurance companies are using the HCPCS codes now as well. So when we specifically talk about the ones that we can use in dentistry, there's the E0485 and the E0486. The 85 is the prefabricated, and you can get on Medicare's website and you can see what that means, but basically they're made in quantity without a particular patient in mind, as compared to a custom fabricated, which includes taking impressions and actually making a mold for a very particular patient.
And do you ever do the E0485? I can say I don't think we've ever filed for that. So pretty much all we're going to be talking about is the E0486 tonight, I would assume. Have you ever had an indication for the E0485?
No, Medicare actually doesn't cover it, and we're going to talk about insurance in general, and then we're going to talk about Medicare. So everything up until we talk about that, we'll try to make the distinction between regular HMO, PPO type insurances and Medicare. But remember that you can bill for other things besides the dental device, and I know you do some of this stuff in your office, Guy.
We have gone in circles on this, and part of this is the reason this is difficult, and I think Rich said no one's done this successfully. I think what you meant by that is no one's been able to really bill for other people without billing services have difficulty doing this. Dental offices have difficulty learning this, and part of it is it's kind of a moving target. It's constantly changing, and that's why it's difficult. And we have gone through cycles where we charged for every thing we could possibly throw at the wall that was legal. You can charge for evaluations. I have a acoustic pharyngometer. You can charge for that. You can charge for x-rays and the impressions themselves and adjustments. Each time they come in, you can charge for an exam, or there's codes for that. When they take the sleep test home for titration, you can charge for that. And consultations, you can charge. The bottom line is you get very limited coverage. It's sporadic on these things. And for a while there, we were charging a lot of these to try to help the patient's amount. And I realized they were getting about $100 more a case, and it was complicating things greatly. Patients were getting confused. Staff was more easily to get it confused. And I think we're a little bit more along the lines of what Rich is doing now and trying to keep it more simple and not doing all these codes. Medicare's new standard, as we're going to talk about in a little bit, doesn't allow for you to bill for these things now. And I really think that's the direction probably the other insurance companies are going to head to. Do you agree with that?
Yeah. And the next slide, I think we've shown this before. It's kind of in that protocol for, as a patient contacts your office, have they been diagnosed or not? And again, we're not trying to complicate things here, but in general, patient comes in and like Guy said, the first question out of their mouth is, does my insurance cover it? And what's my part? So we decided a long time ago as dentists, we didn't want to play that game, but we're crossing a line from medicine into dentistry now. And the reality is that if we don't help patients figure out how to do their insurance, we're going to do 1 in 10 cases. Would you say that's fair, Guy?
I totally agree with that.
Would you say 1 in 20?
And not only from the patient's point of view, the first question out of the physician's mouth, let's go to, say you take your time, you've got your education. Now I'm going to go meet Dr. Smith at the sleep lab and tell him how wonderful dental appliances are and I can help their patients and share all my knowledge. One of the first questions out of his mouth is going to be, does medical insurance cover it? How much is it? Does insurance cover it? And you better say yes. We handle insurance. So how much does it cost the patient? Depends on their insurance. Send them over. We'll see them for free. I think we've mentioned that before. And that's the only thing they need to know, because if you start telling them it's X number of $1,000 and the insurance, we don't deal with it, you're not going to get any referrals ever from that physician. Just check that guy off your list. So you've got to deal with this. And so this slide looks very complicated, and it is complicated if you do all these fees and charge for every visit. It's very difficult to tell the patient what their portion is going to be as well. And I think that's why we've gotten down to pretty much just charging the E0486. You can verify the benefits ahead of time and do a pre-authorization if needed on that particular code. The patient can understand how much that code, how much of their portion they're going to have to pay, and it makes life simple. And again, I think that's kind of the direction everybody's heading anyway.
Right. That's a good point to bring up about the physicians too. The next slide shows the CMS 1500 claim form. You can Google that. I think for $50 you can get 500 of these forms off the internet and just make that investment. That's something that you're going to have to do. There are some softwares out there that will print this form up and do that. I know our software at Dental Sleep Solutions. There are some billing services out there that do this. If you're interested in having them help you do that, you can contact them. I would recommend that you get some referrals in more than one and talk to those people and find out if they're doing this successfully or not. Most of them are charging in the neighborhood of what, Guy, 10%, something like that?
9-10%, I think. Yeah, call their references and see. Problem with the billing services are that they need a lot of information from you, so you've got to supply this stuff to them, and it can kind of become a little bit of a headache, almost to the point where once you learn how to do it yourself, you might be better off. What do you need to send with these claims, Rich? We've got a list here on the screen. You don't have to have all these things for every claim. But you don't always know which ones you need it for is the problem. So if you want to say you want to have a checklist, if you have the things here on the screen, then you've got most of the things that you're going to need to get a claim paid. Pretty much always need a copy of the PSG, or we should put on there HST. It's just nowadays home sleep testing scored by a board certified sleep physician in the state that the patient was in is acceptable as well. So a copy of their sleep test, a prescription from the physician. Oftentimes they'll send this over, but if they don't, you need to call them up and say, can you send me a prescription? Basically to say, make mandibular advancement device E0486 on a prescription pad. LOMN stands for letter of medical necessity. Basically, that's just a letter that states this patient is medically necessary to have a dental appliance for their sleep apnea. You can write your own letter and fax it to the physician and say, do you mind signing this, and faxing it back. That works quite well. The physicians usually have no problem doing that. You used to always have to have a CPAP affidavit, certainly before 2006, to get paid. And basically, this is just a piece of paper and that has check marks for mask leaks, claustrophobia, whatever the problems is the patient is experiencing with their CPAP. And they say why they can't wear it, and they say they've tried CPAP and they can't tolerate it for these reasons. I think it's real important on someone who has severe apnea. As a matter of fact, if it's Medicare, they kind of mandate that they've tried CPAP first, and it's the right thing to do anyway. So medically, legally, I always have one of these on severe patients. And even mild to moderate patients, if they've tried CPAP, I go ahead and have them fill it out, but it's not mandatory if it's a mild to moderate patient to have this. The clinical notes.
Where can you get a copy of that, by the way?
Oh, well, if they want to email us, we'll send them a copy of a CPAP affidavit. I'm sure probably Keller may have them as well. Any other resources that you know?
No, I'm just wondering if you can't just Google CPAP affidavit.
Probably.
If you can't do that, you can email us info@dentalsleepsolutions.com, and we'll get a copy of it to you.
Yeah.
So you're using that with severe patients, and if they've tried CPAP, go ahead and fill it out. But you don't always have to have that one. But you do have to have a copy of the sleep study. You do have to have a prescription. You do have to have the letter of medical necessity.
Both for insurance and legally, I think that you should have those things for two reasons.
Okay, and how often are you finding that you need some kind of clinical notes from the physician?
Rarely that they request. And what these are, this is basically the SOAP note from the physician. It's, a history of present illness, indications for the sleep study, what the sleep study said, so forth. Oftentimes, that's the front part of the PSG will suffice for that. If a home sleep testing, they don't usually give as much documentation, but a lot of times when they send the PSG, it'll kind of have the history and everything on the front of it. That'll be enough to suffice for the SOAP notes. If not, you have to call them up and ask them. There's softwares out there. Sometimes you can use your software that you may have and print a SOAP note from it, and sometimes they'll accept that as well.
Okay, good point. And then the advanced beneficiary notice, that's only for Medicare people, and we're going to talk a little bit more about that later. And we've kind of beat to death the American Academy of Sleep Medicine parameter paper.
They don't need that much anymore. Prior to 2006, we had a lot of troubles, and then when the practice parameters came out in 2006, the insurances denied the claims, and then you had to send that in to say, look, you should not deny this, and then they would pay it. It's not, we don't need that most of the time now, but that's all the stuff. The first three you have to have, and then the other ones it depends on the case.
Very good. So we're going to get all that supporting documentation, hopefully before, right? We're going to call the insurance company and we're going to verify these benefits so that when the patient comes in, we can give them an idea of what they can expect their insurance to pay. Part of that verification of benefits is, do we need a pre-authorization? And if they say yes, you ask that question. If they say yes, they'll connect you with a different part of the insurance company. And then you go through a lot of the same type of things in order to get this pre-authorized. And it's important that you do that, because if they do require pre-authorization and you don't do that, then the patient loses his ability to get reimbursed for this. And that can really come back and bite you. So if you make a device and, you charge $100 and the patient was supposed to get $80 for this, and because you didn't pre-authorize it, that now they can't do that. So again, this is a big can of worms, but we want you to feel confident that there is a process for doing this, for getting that information, getting the insurance company on the phone, and then helping the patient figure out what it is that they're going to pay for. So we file that on the CMS 1500 claim form, and let's say it comes back, Guy, and they deny it, or how do we follow up with the claim at that point? Let's say a week goes by, 2 weeks goes by. How do you follow up with it?
Well, appealing insurance claims, at least our office policy, we're talking about a claim, Rich, that has already been filed and then they don't pay it. Or are you talking about appealing a verification of benefits or a pre-authorization? In general, we won't go through the trouble for a pre-authorization. But in general, what we're going to be talking about here is appealing a claim that didn't get paid. Do you ever appeal before the fact, Rich?
Well, we'll get into that a little bit, and that's in network, out of network, and that kind of stuff. So you can. It just depends on, how much of this battle you want to fight and what you want to do. One of our selling points for our franchise is we do all of that for you. So we're kind of that employee that you don't have to hire. So as you get into this and you do this, you're going to find that it takes a tremendous amount of time to provide this information to the insurance companies and to do it. And it really is a pain, but we've not found a way around it. So let's keep this at this point to appealing a claim that we've already done one. They said they would pay for it, and then they didn't. They came back and they didn't.
Well, it depends on what they ask for, but things we have on our screen here are the things you're going to need to be prepared to have. And it's just easier oftentimes to have that stuff before you even start the appeal process, because once you get on the phone or once you start writing letters and you're trying to appeal something, just the more information you have, the better off you are at getting the claim covered. Supporting documents, you always need a sleep test. We have PSG here, and again, it can be home sleep testing as well. The prescription with the diagnosis, the letter of medical necessity. And now I don't always have the SOAP notes for a claim, but if you're going to appeal it, you might as well go ahead and get it, because you don't want to have to do this, multiple times, even though they may kick it back anywhere or lose it or whatever tricks the insurance company has. But get the SOAP notes from the MD. It'd be the one I would prefer. Oftentimes that is included on the PSG, but if it's not, then get those. And then any peer-to-peer communication. What do you mean by this, Rich?
Well, the first part of that would be filing a letter with this supporting documentation.
Okay.
If it comes back denied again, then we call the insurance company and we request a peer-to-peer review. That's usually where you'll actually get on the phone with the medical director, you as the dentist, and you will say, look, what's the deal? Why are you not covering this? We have a patient in, he has a sleep study, he's been diagnosed with sleep apnea, whatever the particulars are. He's failed CPAP, we've made him a dental device, we're going to treat this guy successfully. What's the problem? What's the hang up? So that's where you get into the nitty gritty with the medical director. And, 10 years ago when you and I started this, Guy, we got into this a lot. I would have to say that as every week goes by, we do this less and less and less, because it's becoming more commonplace, and most insurance companies have heard of it now, and they understand, it's not a dental device. Every now and then you'll get somebody on the phone, they say, well, we don't pay for splints. Well, it's not a splint. Why didn't you file this under dental insurance for TMJ? Well, it's not a splint. It's not for TMJ. You've got all this information right in front of you. It's medically necessary. So we kind of make that argument. And that would be the second step to that appeal process. And we encourage the patients to call and do the same thing. And it's one of those things where, the squeaky wheel gets the grease, so to speak. The more the patients call, the more they hound them, the more likely they are to get this covered. And we put as much of that on the patient as we can. Okay, next. Medicare. Oh my gosh, is this a can of worms? So again, this is another 8-hour lecture, and you guys are going to get it in 10 minutes here. But in general, there are a few things that you can do to help your older population patients. Medicare is anybody 65 and older. So as a dentist, of course, you have to decide if you're going to become a participating provider, a non-participating provider, or you're going to opt out. There is a Part A and a Part B. Part B is the Medicare, the DME part that we deal with. Part A would be the exams and follow-ups and things like that. So let's kind of just start this conversation. And the next slide shows you the durable medical equipment regional carriers regions. So if you're in California, you're in Region D, and if you're in Florida, you're in C, et cetera. So these are each administered by different insurance companies. Medicare contracts with Humana, for example, or Aetna to administer these contracts for them. And then that's who you have to deal with through this. So again, we're going to try to simplify this as best we can. But the coding itself, we have the descriptors for you for the E0485. And again, that's the prefabricated one. And the E0486, which is the custom device. And again, all we're using is the custom device anymore. We're not using the 485. But if you wanted to do a 485, you could file that under a patient's regular insurance. Medicare does not actually cover those. Okay, the next slide, we have the Medicare process itself.
Let me just back up for just a moment. I liked everything you said, and you were on a roll there and giving a lot of good information. I think we might not have addressed the decision as to what one of the three you want to be when it comes to Medicare quite adequately. You have to make a decision here. You didn't about a year or two ago because Medicare didn't cover these, and then they came up with codes, and then they assigned no dollar amounts to them. But now they're covering these, and they have their dollar amounts for the whatever region you're in, and legally, if you're going to see Medicare patients, you're supposed to decide on one of the three. Again, we could talk for hours about it, but to try to simplify it, easiest thing to do is to opt out. Opting out is where you just basically say, I'm not going to deal with Medicare. And the patient, by coming to you, loses their Medicare benefit. And that's why you want to have the opt-out affidavit with those patients. When they come to see you, they sign this saying, look, I know I'm coming to you and you're not dealing with Medicare and I'm losing my Medicare benefit from coming to you. If you decide to opt out, that's a 2-year deal. You fill out some paperwork. All three of these decisions require you to do something. You have to fill out some sort of paperwork. And you've opted out. You're committed to opting out for 2 years and can't get back in. Again, that's the easiest thing to do, but it may not be the best for your patients. To be a participating provider, you're agreeing to...
Hang on a sec, Guy. So if you opt out, you just sign a contract and you opt out. So you're agreeing that you cannot bill Medicare for what you're doing. And the patient, by working with you, is agreeing that they won't bill Medicare either.
Correct.
So you're completely outside of the scope of Medicare at that point.
Right. You can charge as much as you want for these things. Basically, the government's saying they've washed the hands of it if you're doing this. And the patient can't go file it on their own either. That's why you need to have them sign that opt-out affidavit in case they try to file it, and that keeps you from getting in trouble that way. Okay, so the other two choices are participating and non-participating provider. I'll talk about participating provider first. That's at least easy conceptually to understand. It requires you to fill out about a 100-page application. I don't know if it's quite 100, but it's a lot. And you become a provider, and then you agree to accept Medicare for these patients. You have to legally have to file for any Medicare patient that comes in, and you have to accept what Medicare pays, their billable amount, which is different for different regions of the country. Typically, the way it works, there's an amount that Medicare covers. Let's say it's $1,000 in whatever region, and then Medicare would pay 80% of their allowable fee directly to you. So in this scenario, they'd send a check to you for 80, and the patient would be responsible for 20% of the other, which would be $200 in that scenario. If they have secondary insurance, their secondary insurance would cover that difference. Okay, so that one's pretty simple, at least to understand. You're committing to that you have to accept that fee, and you can't legally charge anything more. Non-participating provider, basically you're a provider, you have to fill out the same paperwork, but you're saying that the check's going to go to the patient and the patient's going to pay you. And I'm not going to get involved in the details because it's kind of controversial as to how much you can charge if you're a non-participating provider, but you may be able to charge different amounts than maybe above what Medicare reimburses if you're a non-participating provider. Patient pays you, and then the check goes to the patient. So you've got to kind of make a decision, and not if you're going to get involved in this as to which road you're going to go on.
That's good. We do have a question here though that says, why would I sign up to be a participating provider, or why would I be a non-participating provider? I think it's pretty easy to decide. If you want to opt out, you just don't want to deal with it, right?
Right. So
if you're in a community of younger people and there aren't hardly any old people there, I doubt that's the case in South Florida or where you are, Guy, but no. At least half the year anyway, right?
Right.
And you touched on most of that, but as I understand it, if a patient has a choice of who they can go to in their community. Let's say I'm 65 and I want to go get a dental device made, and Guy is a participating provider, and John Smith down the road is a non-participating provider. And I don't have any secondary insurance coverage. Medicare is my only insurance that I have. I would probably choose to go to you because I know that this is going to be an easier process because you are participating, and my copay that's there, that you've already agreed to those fees and everything, and you're not going to charge me more. Is that correct?
That's correct. And you can say the same thing if you are non-participating versus someone who opted out. At least they're getting some benefit from coming to you. And the reason that this is kind of the can of worms is because the amounts that Medicare is paying has been kind of boggling all over the place, and it's been unclear as to what they're going to pay. It's kind of coming clear as of September 3rd this year. They set some new fees, and then at least in my region, it's just barely over $1,000 that they're covering. I think out in California, it's near 1,900 if I'm not mistaken. I don't quote me on that, but so it depends on what area you're in, and you have to ask yourself the question: and when they're paying this, can I afford to do this for that amount? And that's the decision you'll have to make in your own office. If you become a non-participating provider, there's means and ways that you can charge more than the Medicare amount, and the check can go to the patient, but then the patient has to pay you. It's not as big a benefit. But if you can't do it for the amount Medicare pays, then you're going to have to consider being non-participating or opting out.
Right. And again, this is a moving target, but as we understand it, one of the difference between participating and non-participating too is that there is a difference in the allowable fee. So as a participating provider, they will reimburse slightly more than for a non-participating provider. That's one of the ways that Medicare has designed the system to try to steer patients towards going towards their provider list. But the benefit of being a non-participating provider, as we understand it, is that you can balance bill the patient for the difference. And if they have a secondary insurance, then that's already on file with Medicare. And when Medicare pays their portion, that essentially goes to the secondary provider to try to pick up the difference between what Medicare allows and what your fee is.
Correct.
Again, it's a can of worms. So
yeah.
Thanks for pointing that out, Guy. And I hope we made that a little bit clearer. And there's several questions coming in, and I think we addressed most of them as we do that. But
right. And if we sound a little confused on the subject, it's not that we're confused. It's that Medicare is confused. And if you call there and talk to them, which we've done many, many times, you get a little different story each time you call. And I think as this year goes on and next year comes around, it's going to kind of become more distilled, but right now it is kind of a moving target, and we don't mean to be ambiguous on it, but that's just because it's changing every day. Okay, back to the process.
There are a couple of forms that you have to fill out, okay, in order to do this, in order to participate. So if you want to be a participating provider or a non-participating provider, then this is what you need to do. There are basically four forms. The 855I, and that gets you to become a Medicare provider. The 855S is the application that allows you to become a DME supplier. And again, you have to remember, Medicare treats DME as a separate entity. Someone who distributes CPAP, for example, at a DME supply store in your community would have to become a DME supplier. They would have to do that. But they can't become a Medicare provider because they're not a physician. So again, not to confuse or muddy the waters here, but as a dentist, we're both a provider and a DME supplier in this particular instance. And those are the forms that you have to do that. And a couple slides later, I think we have some links that you can copy. In fact, yeah, there it is there. I think that's the next slide, right, Guy?
Yes.
Yeah. And we're going to leave those up for a minute so that you guys can write those down. But it's basically just cms.gov/CMS forms/downloads-CMS. And then you have 855I, 855S, 460, or 588. And those are the other two forms that you need to have there. So that's how you can get those, and you can get those applications. You can we highly encourage you to do this online. You can follow that link, and it will give you a PDF of the application process itself. You can download that, and then you can actually fill it out and mail it in. There are also links on the site which you can go to that will allow you to do this online. And the online versions are much easier to do. If you have a question, there's a little thing that says help, and you can click on that. So that makes it much easier to make this application process less painful. Like you said, I think the 855 INS are both about 40 to 50 pages, somewhere in there.
Yeah.
And there's a checklist and lots of things that you have to do and all that other stuff. So.
And if you don't get those links written down, you can email us at info@dentalsleepsolutions.com, and we'll email you the link. It just takes time, and so someone in your office has got some time and are good at filling out forms and answering minutia questions, then have them do this.
Right.
Make a decision, though, one of the three. All right.
Let's talk a little bit, Guy, about the LCD. What does that stand for, and what is that, and what's the deal with Medicare and all this stuff?
Okay, what does LCD stand for? Is that local coverage determinant?
That's exactly. It's a local coverage determination, and that's what Medicare has come out with recently and said, okay, look, we're going to cover these dental devices, but you have to meet certain criteria in order to do that, and you see them listed there.
Face-to-face with the treating physician prior to the sleep test. One of the things I guess we should bring up at this point is if you are a Medicare provider, either
participating or non-participating.
Participating or non-participating, it doesn't matter either way. Then they've specifically said that dentists cannot have anything to do with the home sleep testing procedure. So in addition to that, the patient, before they get a sleep test, they have to have a face-to-face with the treating physician prior to the sleep test being scheduled. So in other words, they need to go see their physician, and the physician needs to evaluate them and say, yes, you need to have a sleep test. And then they have to meet certain criteria. So just if they have a sleep test and they have an AHI of 5, that's not enough to get them coverage. It needs to be an AHI or RDI of greater than 15. Or if it's above 5 and less than 15, then they have to have documented excessive daytime sleepiness, impaired cognition, high blood pressure, I think
ischemic heart disease, history of stroke. They basically have to have some of the other comorbidities of sleep apnea.
Correct.
They can't just, have an AHI of 7 and they're going to cover it. And that's usually not hard to do because most people can say they're sleep.
And if the AHI is above 30, then they have to try CPAP first, or there has to be a reason why CPAP is contraindicated. And that's one of the reasons we mentioned earlier that CPAP intolerance affidavit is important to have for your legal medical records in case Medicare audits you down the road, which they like to do if you're a provider, so that you have all your ducks in a row for that. You need a prescription for the oral appliance. It's billed by the dentist. It's your obligation to bill Medicare for that. You can't say, here, patient, you take care of this. If you become a provider, you legally have to submit all the claims to Medicare.
Very good. Okay, well, we've tried to cover a lot of that and to make that process easy. On top of that, okay, there are certain devices that you have to use. Only these devices, as of November 2011 here, are these acceptable by Medicare, and you see the list there.
And that's growing. They just mandated that they be approved. When was it? September 3rd, Rich?
Something like that.
Something like that. And so, I checked this a month ago, and there was I think TAP was the only one on there at first. So the other ones will slowly be added to it. But you need to make sure that the device you're using is approved. And I don't think we've mentioned that the only code that they will really pay on is the E0486. We briefly mentioned it, but that's called a bundle fee now is what Medicare has determined. And so all of your appointments for fitting and titrating the appliance for 90 days is included under that one fee that they're going to pay you.
Right, and they call that the global fee.
Right.
And we're kind of getting some feedback now that they're saying that that's going to be a 5-year deal too. So you'll be able to charge for follow-up visits and repairs and things like that. But at this point, they want those devices to last for 5 years, and that can be a little bit of a challenge. So, as dentists, we're going to welcome to medicine. I mean, at least you're a dentist and not a physician, and you've not been dealing with this. You're the last 20 years. We only have to deal with it now in one aspect of what we do. But what kind of decisions do we have to make, Guy, in the big sense, not just Medicare itself, but as far as insurance goes?
Well, I like the slide you put together, Rich, because these are questions you're going to ask, and you're going to have to decide what your office policy is going to be. Are you going to file insurance or not? I'm going to go out on a limb and say if you don't deal with medical insurance by at least filing it, let your patients know you're doing what you can to get their reimbursement at the very least, and maybe even accept assignment of benefits in some cases, you're not going to excel in this area. I've run 20 years running a fee-for-service dental office, and it really goes against my grain, but you're just got to deal with medical insurance if you're going to get involved in this. I don't know if you agree with that totally. I think you probably do.
I do. I
don't think we're going to get in the game unless we do. So however we can help you, there's services that can help you, you're going to have to deal with the medical insurance. So I think the answer to that first one is going to be yes, you need to deal with it if you want to get involved. But you have to decide, is it possible? Anything's possible. You might be able to do this in your office and just have them pay you and not deal with it, but it's going to be a really steep hill. Now the next thing is, Rich can attest to this. I know you're have a couple of contracts. Weren't you one of the first dentists to get a contracts with the medical companies for services?
Yeah, and what this is we call it going over to the dark side, right? I mean, but if you're serious about this and serious about doing it, this comes back to that in-network and out-of-network type of thing. And we've had a couple of questions about that. So I'm gonna bring that up again real quickly. I know we're running out of time, but I had a situation come up recently where a patient came in and we want to make them a device and we do the pre-authorization and all, and it comes back and it says, we won't allow out-of-network benefits with you, Dr. Drake, because we have a dentist who's in network. And I said, well, who is it? And they said, it's Dr. Smith down the road. And I said, that's funny that you would say that because I called Dr. Smith, and Dr. Smith is an oral and maxillofacial surgeon, and he doesn't make dental devices to do this. He's in network with you because he does do other medical procedures. So again, this is one of those things, one of those hurdles that you will run into as a dentist. So at that point, you can say, well, look, I'm interested in becoming an in-network provider, and then they have their accreditation process and they have their own application, and you have to go through this whole thing, and then you have to negotiate a fee. So the upside to becoming a preferred provider with a medical insurance company with this is it does streamline the process. It does make it easier for you to get reimbursed. The downside is that they're going to try to lowball you on the fees. They're going to try to get this fee reduced. And I just stuck to my guns, and it took me 20 days to fill out the application and get it to them, and it took me a year to negotiate a fee. So I think as dentists, we just need to be reasonable about what we're willing to do this for. But you do have that option to become an in-network provider, and they're glad to offer that to you, and you can set that whole wheel in motion. And we can't, as dentists, decide we're all going to do it or not all going not to do it. There are laws that prevent us from doing that. So we have to make these decisions ourselves.
Right, and if you don't have anybody in your area who is in-network, who's doing appliances, then oftentimes you can get pretty good coverage by what's called the gap clause. I think it's called. We file for in-network benefits since there's no one around who is in the network. But the moment someone in your neck of the woods decides to start doing this and become a provider, then that gap clause is not going to be beneficial. So I think that's a moving target. I think more and more people will become contracted as the years go on. Right now, there's not a whole lot of dentists who have done that. Rich is one of the first in the country who did that several years ago. As far as what you do with Medicare, you're supposed to do something. So sticking your head in the sand and saying I'm not going to deal with it's really not supposed to be an option. So go on over them, you make your own decisions, find out what Medicare is paying in your area. Is it worth it for you to take that? If it's not, then decide if you're going to opt out to be a non-participating provider. I can tell you I'm a non-participating provider. We're able to get more than the Medicare amount, at least currently, with the way the laws are. And again, it's changing daily, and that may not be true next week, but today it is. So that's what I'm doing. The one thing we should mention while we're saying this is we've given a lot of advice on how we do things. You need to check with your state laws, and we're not attorneys or experts on every state of dental laws and medical laws. And this is general 50,000-foot overview advice. Any specific decisions need to be made within the jurisdictions that you're in, and we certainly don't know every state's laws and so forth.
Very good. Okay, we're wrapping it up here. Thanks again for spending some time with us. I want to tell you about Keller's webinar special real quickly. You get a sample kit for $49 that includes an EMA device, a TAP DVD, patient brochures, Epworth scales, coupon for your next TAP case, and a sample letter of medical necessity. Keller at kellerlab.com. We love working with these people, and we hope that you will take advantage of that. And we want to talk also about our upcoming courses.
Yeah, it's really exciting. We're working in the process with Keller of setting hopefully near a dozen courses throughout the country next year. They're going to be priced just right. I mean, we want a lot of people to attend. The one in San Antonio that we did recently turned out great. We had a lot of positive feedback from that. We're doing this for $195 for a full day of sleep medicine. So I think you're going to really get your money's worth. It's certainly not that much, and we want to really fill these classes up. We're also going to have for a select group, a limited number, some hands-on available for the second day at each of these courses as well. The first ones, we do have a few dates for you now. Keep checking our website, Dental Sleep Solutions, and Keller's website for the complete list when we have those out here, likely in the next month. But I think the two dates that we have so far, January the 20th and 21st in Kansas City, and then the 23rd and 24th of March in St. Louis. Again, $195 for a full day, and then we're limited to 5 or 6 dentists on the second day. Any questions that you have, feel free to contact us at dentalsleepsolutions.com, and we can tell you more about the courses. Actually, you sign up through Keller on those, but we're happy to answer questions as well, or talk to you about anything else we've presented. And just a little bit more house cleaning, just to reiterate, make sure your credit, when you receive your email, respond to it, answer the question on the 10-question quiz correct, and then enter in the required information, and then put your AGD number or not applicable if you don't have one, and you'll get your CE. We appreciate you attending. Here's our contact information. There's Keller's contact information. If you have any questions, email us. We'll be happy to get back to you. Specifics about our franchise opportunity, be happy to talk to you about that as well. And I'm sure Keller can answer all your laboratory questions. We really appreciate everybody taking your time and listening. A lot of you, looks like, listen to all 6 parts of our series, and it's been fun, and hopefully it's been a benefit and getting more dentists out here doing this.
Thanks again, y'all. Have a good evening.
All right. Good night.